Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. Juan Fernandez Miranda. Dr. Fernandez Miranda is Professor of Neurosurgery and Medicine and Surgical Director of Brain Tumor, Skull Base, and Pituitary Centers, Director of Neurosurgical Training and Innovation Center, Neurotrain Center at Stanford University Medical Center. Today, at the 2021 IWBNC, Dr. Fernandez Miranda is going to share his lecture, Modern Skull-Based Surgery, 6+1 Skull-Based Approaches. Please direct your questions in the Q&A section. We will read them after the end of Dr. Fernandez Miranda's intervention. Welcome, Dr. Fernandez Miranda, and thank you. It's all yours.
Thank you again for having me this year. It is my honor and my pleasure to be with you guys. Again, congratulations on your excellent work with these online sessions that are highly educational. I want to start, as I should, acknowledging some of my disclosures. These are the JFM dissectors by KLS Martin, and this is the new dissectors that I designed with Hotry for endoscopic and open skull-based surgery and microsurgery. This is the place where I work at Stanford New Hospital. Phenomenal place with a phenomenal team, like the one you see here, my ENT colleagues that routinely work with me both for endonasal and lateral skull-based surgery. And also my team in the laboratory. As you know, I've had a dedication to the lab for many years, and I continue the tradition of Professor Roton. And here are my lab members and my team doing phenomenal work as the one you're seeing here. This is a dissection done by Maximiliano Núñez from Argentina, who I believe is the best anatomical dissector I've ever seen. He does this spectacular artistic work and illustrates the anatomy with his dissections almost like Da Vinci. We call him Max Da Vinci because of his expertise and his tremendous talent in doing these dissections. And Vera, who is from Italy, also working with me in the lab for over a year now, she creates these phenomenal models for visualization of the anatomy. So you can actually access this in our webpage in the lab if you guys have interest and you want to explore the anatomy of these spectacular dissections done by our team in the laboratory. So today I want to talk to you about this concept of multi-corridor skull-based surgery. And this is a dilemma that we all as skull-based surgeons face routinely, which approach should I use for this particular tumor, this particular lesion? Should I go transcranial? Should I go endonasal? For some surgeons that are especially on the older school, the endonasal approach has a small role because they have not developed the expertise. It's not part of their armamentarium, or is very limited part of their armamentarium. But for some of us that we've grown and developed along with the skull-based endonasal surgery, endonasal approach is a big part of our practice. And I want to illustrate to you how this fits in our practice. I want to follow the example of our beloved master, Professor Lawton, and his 7 series. And when they asked Mike why 7, he said, it's a mystical number. But most importantly, I think the human mind can remember 7 things easily. And this is a very smart thing to do. And I really like how Mike put this together in such a didactic way. And I thought, and I know some of my skull-based colleagues also thought about how to put together 7 skull-based tumors or 7 skull-based approaches. And while I was thinking about this, I was thinking, well, if I look at the skull-based surgery, I think more than 7 approaches is 6+1. And the 1 is the endonasal approach, because this is the approach that can be compared or combined or use instead any of the other 6 approaches. I selected 6 because are the most common used 6 skull-based approaches in my practice. We can argue long on whether you want to have more or less than these, and you can definitely have more. But as Dr. Lawton said, 7 is a good number to memorize, and it makes it easier for us to understand. So these are the 6 approaches I want to compare with the endonasal approach. I'm going to go carefully reviewing these approaches in different areas. We're going to start with the cruciform region and frontal sinus. We either can do an endonasal transcruciform approach, or we can do a subfrontal transbasal approach for lesions in these areas. Olfactory groove meningiomas are always a significant tumor in this area. Should we go endonasal? Should we go transcranial? There is a lot of polemic and controversy about the right approach for these tumors. And when I look at this, there are two things that I want to look at in these tumors. One is the sense of smell intact or not. If it is intact, I do not want to do an endonasal approach. Two, is the tumor having a significant lateral extension beyond my reach to the endonasal approach, in which case I would not use an endonasal approach. And here you have two examples, and you can see the pre and post on both examples. One was done with an endonasal approach. It's a medium-sized tumor in a patient with no olfaction. This we can do endonasally. The other one is a larger tumor, no olfaction either, but it has too much lateral extension. It's not good for endonasal. I currently do very few olfactory with meningiomas through an endonasal approach. I do, and it is because the ones that are small, most of them have the sense of smell preserved, and therefore endonasal I don't think is a good choice. But the large ones like this one, these giant meningiomas, which are the most complex ones, I don't like to do endonasal anymore because of the risk of CSF leakage, and because it takes too long and it's too complicated, and actually because I can do a very good skull-base approach. I like to do this modified subfrontal craniotomy for this type of approach. If you see the cut of this craniotomy goes just above the orbital rim and goes down to the frontonasal suture across the anterior tibia of the frontal sinus, and you need to drill or fracture the posterior tibia of the frontal sinus. The beauty of this approach, as you see in this picture, is it takes you right to the skull base. So when I'm done with the craniotomy and I cranialize the frontal sinus, I see the crista galli, I have access to the bilateral olfactory sulcus, I can go all the way to the plantar sphincter, all without touching or manipulating the brain. So this is a real skull-base approach. I love it for these tumors. It has minimal brain manipulation. I can use a pericanal flap for reconstruction. I can tailor the amount of skull base that I drill. And therefore, this is my favorite approach for this type of giant skull-base meningiomas. I know some of my colleagues prefer to do pterional or even eyebrow approaches for these tumors. I do not like that because those are not good skull-base approaches in my opinion. If you're going for a good skull-base resection, I think this is the best approach for these giant tumors. For sinonasal malignancies, of course, there are tumors we can do only endonasally. And there are many that they have limited intracanal extension, and endonasal approach is great. But there's some others like this where we have to combine. This is a giant olfactory, this is a giant stichioneuroblastoma. This is a tumor that no way you can do endonasally only, of course. And of course, this is a really challenging case because you can see the invasion of this tumor. And I want to illustrate with this case how we can very nicely combine endonasal and modified subfrontal approach. And here endonasally, I'm doing most of the skull-base resection. I can go easily through an endonasal approach all the way to the tuberculum sella, detach the tumor from both optic canals, open both optic canals if needed, and get the posterior aspect of the tumor, which is the most difficult to get when I go through an open approach. And at the same time, combine with an open approach, as you see here. And we have both corridors open, endonasal and transcranial. Now, again, this is a massive tumor, but we were able to get a complete tumor resection. We follow margins. As we have an open craniotomy, I can follow margins as wide as I want. And the challenge here is going to become the reconstruction. This is our pericanal flap that we used in this case. Fascia lata multi-layer reconstruction. In this case, actually, it failed. The patient had a pneumocephalus a few days post-op, and when you have such a large defect, I don't hesitate to go directly into a free microvascularized flap, like a formal flap we did in this case, with, as you see here, a beautiful reconstruction and a very good outcome for this patient. Now, is it all about endonasal or open? So do we have other options? For example, this frontal sinus encephalocele. This tumor, this encephalocele goes too high and too lateral to be done endonasally only. So in this case, I decided to do an endonasal approach urinarial, but especially we did this medial transorbital approach, also called transcaruncular approach. You just cut through the caruncula of the eye. And this is a beautiful approach because it gives you direct access to the ethmoid and medial frontal sinus. And this is done without any need for a skin incision. There is no incision in your eye or in the skin, I would say. It's in the eye. So there is no scar after the operation in your face at all. And through this window, I can open directly into the medial aspect of the orbit, enter into the frontal sinus. And this was completely full of encephalocele that we are removing. This is endoscopic assisted transorbital approach. At some point, we introduce the endoscope to the nasal cavity and we work through the transorbital route. So this is to illustrate how we can innovate and bring new approaches that are less invasive and better for our patients. You can see that defect right there. We can coagulate. You see at the end is a small cranial skull-based defect that we can easily patch with a free mucosal graft and then some glue for this patient. And this patient had, a nice resection. Now let's move on to another area, the area of the planonis fingale and the tuberculum sella, another controversial area. And here to me is very important to differentiate supracosmetic versus infracosmetic region, because I like to do different approaches depending on where I'm going. The two alternatives are the orbitofrontal approach or supraorbital approach and the endonasal approach. Remember, one is a lateral approach and superior, the other one is a median approach and from inferior. We have here these tumors, and the question I have when I see these tumors is, what is the optic nerve or what is the optic chiasm in relation to the tumor? If the optic chiasm is displaced inferiorly or posteriorly, like it happens in this tumor down here, is the optic chiasm. I can go endonasal, but I don't think it has a lot of benefit going endonasal. And if I look at this tumor, it goes too lateral. So this is one tumor I would do through an orbitofrontal approach. I see this tumor up here. This is a true tuberculum cell meningioma. What is the optic apparatus here? It's going to be displaced posteriorly or wrapped around the tumor. This is a case where I would like to do through an endonasal approach because of less manipulation of the optic apparatus. So this is that, meningioma done through an orbitofrontal approach. You can use an eyebrow incision. You can use a conventional incision behind the hairline, depending on this patient was partially, he had a good hairline. I decided to do better an open approach, incision behind the hairline, which cosmetically looks really good. You can see here we have good access all the way to the folks. I do not hesitate to remove the orbital roof in these patients for surgery because it gives me better access. It minimizes the manipulation of the frontal lobe. I think patients do better when you manipulate the frontal lobe less. There is less brain edema, and you can do a better skull-base operation that way. And you see here we are now carefully dissecting the olfactory tract to preserve olfaction, of course. And this approach really gives a nice panoramic view of the whole anterior skull base, from the anterior clinoid process all the way to the cruciform plate. And I can actually remove the dura. I can drill the bone. I can do a very complete resection for a tumor like this. Now, when I started struggling in a case like this is when I go to the extension of the tumor underneath the optic apparatus in the infracosmetic space. And that is when I think the endonasal approach has a lot of power, because that's an area where to reach well through an open approach, you have to manipulate the optic nerves. You can do a craniotomy on one side, but how about the other side? So it is, I think, the disadvantage of this approach. But if the tumor is mostly supracosmetic, it's a very powerful approach that allows you to do a true skull-base approach and resect all involved tumor and dura. So when we look at the area of the infracosmetic space, here's an example of a tuberculum cell meningioma. And as it grows, the displacement of the optic apparatus is such that the optic nerves are being wrapped around the tumor. And any degree of manipulation of these nerves from an open approach above, can decrease the visual recovery. That's why I think the endonasal approach is such a good option for these tumors. I know this is controversial, and still, especially classical surgeons with no expertise in endonasal skull-base surgery, they argue about doing these approaches through an orbitofrontal approach. I think that's perfectly fine. But I do believe, my opinion, that the nerves here are really trapped by the tumor. You can take one clinoid, but the other one is you cannot take both clinoids in this case. I do think an endonasal approach, in my opinion, and in my experience, is superior than an open approach. In fact, there are meta-analysis studies. Dr. Schwartz was the main author on one of those, showing that this meta-analysis, that visual outcomes are better for endonasal approaches than for open approaches for these particular tumors. You can see the phenomenal visualization you can get with this approach. I'm looking at the ACON complex and the small perforating vessel, probably a subcallosal artery that is so important to preserve. And I can see it, I can preserve it I can see all the microvascularization of the optic chiasm and be very meticulous with my technique to preserve it. You can see those superior hypophyseal artery branches and carotid artery perforated branches that I can very nicely dissect. Now, you require a very precise, meticulous technique with this approach. Some surgeons say you cannot do nice operation through the nose. It's not true. You can do very nice operation like microsurgery with beautiful preservation of all the vessels and following strictly the principles of microsurgery, but just done with an endoscope as visualization.
This patient.
Another example of an interesting case. This is an optic nerve sheath meningioma. Now, what do we do about this case? Traditionally done through craniotomy or not operated, just radiated. In this case, it's a type 3. This tumor is encasing the optic, is on the optic nerve sheath, but it's also growing to the tuberculum cell area in the cisternal space. I do think that endonasal approach is ideal for these tumors because I can really decompress the optic canal very widely from the apex to the cisternal segment. And then if there is cisternal extension, I can open the dura, tailor the dural opening for the tumor, and really take the tumor that is compressing the optic nerves, as you will see in this case. You can see here the carotid artery down here, the suprahypophyseal arteries. I trim this at the level of the distal dural ring. I can open the optic canal dura, as I'm doing right now with this right angle knife. And then I can very carefully dissect the tumor away from the optic nerve. You do not have the same degree of visualization and access to the optic canal with an open approach. The endonasal gives you, there is no question in my opinion, better approach to this area and better visualization. And I can very carefully remove tumor from inside the canal, as you are seeing here. One second, something has stopped. Okay, sorry about that. So, so that's a nice example of an optic nerve sheath meningioma. Let me move on to the next region. This is such an interesting region, one of my favorite to operate. The paracranial region, middle cranial fossa, cavernous sinus, petrous apex, all of this area of the middle cranial fossa, right? So here again, we have the choice between extended Middlefoss approach or Middlefoss approach, extended or not, and the endonasal transpterygoid approach for these areas. So here you have two different tumors. They look quite similar in shape, both young patients. So this is a 27-year-old female present with 6-nerve palsy, partial, and this tumor. And this other one is also a 28-year-old male present with different, with trigeminal neuropathy. So when I look at these tumors, I think, where is the carotid artery in relation to the tumor? Is the carotid artery pushed backwards or laterally, like in this case up here? Or is it pushed anteriorly, ventrally, as in this case right here? Of course, I look at what pathology I think this is. This looks like a chondrosarcoma, right? There is no question based on the imaging. And this is a case that I think is perfect for endonasal surgery. As perfect as it can be, just because of the location and the access is ideal for this tumor. This is a different tumor that maybe looks like a meningioma, but the carotid is pushed forward. This is not a good case for endonasal because the carotid is in my way. I have limited window. I can do a beautiful Middlefoss approach and take good care of this patient that way. So what is the carotid artery? This is the resection through a Middlefoss approach. You see complete tumor resection, megaloscape now is re-expanded. This was a hemangioparasitoma, grade 3, so he needed radiation post-op. Beautiful operation through a Middlefoss approach. This is a chondrosarcoma. And this young patient with 6-nerve palsy presents again with diplopia. This, you see the carotid is displaced laterally. And this is very important because this gives me a huge window to access the tumor. Now, of course, this is an approach that you need to know how to do technically. First, the key is the transpterygoid approach. What we're doing here is we're removing the sphenic process of the palatine bone, so I can identify first the palatovomeral artery and then the palatosphenoidal artery, which is so important. Once you identify the palatosphenoidal artery, you coagulate and transect it, you can identify the Vidian canal and the Vidian nerve. So now I can drill the pterygoid up to the Vidian. And next, I want to find a key landmark, which is the pterygosphenoidal fissure, as we described. And this triangle between the Vidian and the trigeminal fissure, we need to drill, is going to give us access directly to the foramen lacerum. The foramen lacerum is the epicenter of many of these chondrosarcomas. And there is no question, in my opinion, that is a big middle cranial you can see there. There is no question, in my opinion, that endonasal approach is the best for a tumor like this, whose epicenter is at the foramen lacerum, as you see here. That we're coagulating there the pterygosphenoidal fissure. Now we're transecting it. And this transection is what starts the sublacerum approach, gives me access to the inferior aspect of the petrous apex towards the lower petroclaval fissure and jugular foramen where these tumors extend. I can identify the carotid. I can remove the tumor. Again, the carotid is displaced lateral. That is the carotid right there. In fact, this case did not invade the cavernous sinus, just displaced it. The tumor is merely in the petroclaval fissure. And now you can see the petrous carotid right here. And now I can see the petroclaval fissure. What a nice view of this petrous bone here, claval bone, petroclaval fissure, carotid displaced superiorly. It's a complete tumor resection with margins, with decompression of the sixth nerve, without touching the brain, without any manipulation. Endonasal approach, no question, is the best for chondrosarcomas, most of them, in my opinion, in particular this one. Okay, other type of tumors in the middle cranial fossa. These are two different animals, right? This is here is an anterior canal meningioma. This is something more unusual. Looks like a pterygoid, a sphenoterygoid meningioma. Very different. We're going to treat this very differently also. So this first meningioma, anterior canal meningioma, we need to do what is called the Hakuba-Doleng technique. Okay, and this is just such a beautiful approach. I think this is real skull-based surgery. You peel the middle fossa dura. We are seeing GSPN and drilling the foramen spinosum to get the middle meningeal artery. I find V3, and then I dissecting the clinoid really well. The supraorbital fissure has been all exposed, and I'm working all extradurally without touching the brain, drilling the clinoid, decompressing the optic canal, taking the tip of the clinoid, optic strad, that's the clinoidal carotid, so that I have detached the tumor from the skull base. And now this basically also almost become a convexity meningioma after doing this. After debulking, I can go again to the skull base, and I can enjoy the extra and intradural aspects of the approach. I can cut the falciform ligament, I can cut the distal dural ring, and I can cut along the tentorium and petrocranial ligament to detach the tumor from the dural attachments at that area. So that's the optic nerve. I just cut the falciform ligament. The next thing after the falciform ligament is the distal dural ring, which I coagulate and cut, that exposes the carotid, supracranial carotid. And the next thing after is going to be the third nerve and the anterior petrocranial ligament. The beauty of doing this extradural first is that I have excellent control of the most important structures, the carotid and the optic nerve, at the beginning of the operation. What you see there is the third nerve, and it's the third nerve that is being compressed, and the brainstem. And the next step here, the next move is the Doleng technique, where you cut this petrocranial ligament. And this allows me to mobilize the dura of the wall of the cavernous sinus. And is what ultimately allows me to remove the tumor completely. So this is the proper way of doing this clinodal meningioma. I've seen this done the wrong way, Transorbital approach, attacking from the brain side. That is a mistake. That is not a skull-based surgery technique. This is a tumor that needs to be done from the skull base, and from the skull base towards the brain, not from the brain towards the skull base. We start with the clinoid. We do not end with the clinoid. I think that is such a very important concept for skull-based surgeons and to make a better outcome for our patients. This other case, this more unusual meningioma, is an incidental finding meningioma and a patient with Parkinson's disease. And we first did a biopsy, and the biopsy came back as an atypical meningioma. So this elderly patient and fragile, what do we do with him with this meningioma? We could radiate it entirely. That's one option. But we said, okay, let's do an endonasal approach, in which case I think it is very useful to do a pre-op embolization of the IMAX, which we did. And then we're doing endonasal. And you see the pterygoid, the tumor is coming from the pterygoid, and now it's coming from the lateral wall, from the middle wall of the cavernous sinus, and middle cranial fossa dura. And you see this is V2 right here. Now we're detaching the tumor. Now we're on the floor of the middle cranial fossa. This is the median canal. This is the carotid artery. Again, I use the pterygosphenoidal fissure, find the carotid, expose it completely. This is the median canal, a median nerve, which I cut and transect. It's all involved with tumor. And then I'm gonna put this stitch here to do a transposition of the pterygopathine fossa, go behind it. And then I'm starting to expose the dural, the middle cranial fossa. And I'm going to now find from V2 to V3. This is V2 right here. This is the dural, the middle cranial fossa. And then I am cutting the dural, the middle cranial fossa, looking for any residual tumor here. You see V2, V3 here, and all the drill the middle cranial fossa floor all the way to the petrous apex, and the petrous carotid is located right here. So we can do all this work through an endonasal approach and achieve a near complete resection, and then send the patient for radiation of the tumor field. It came as a grade 3 meningioma. So there are some tumors that are become very challenging in this area. This meningioma, speaking of meningiomas, right? This meningioma was this small in 2018, presented with trigeminal neuralgia. This was missed, negative MRI. Wait a couple of years, look at what happens. Actually, 18 months later, this tumor has exploded. There is tumor in the cavernous sinus, outside the cavernous sinus in the middle cranial fossa, and towards the posterior cranial fossa. And this patient is very symptomatic from this tumor growth. Now, what do we do about this tumor? So we do, as we saw before, a Hakuba Dolen technique, but we need to add another surgeon technique to the pile, which is the Kawase technique. We need to also go and do a petrosectomy so we can get access to the tumor in the posterior fossa. We can go below 5. We can open Meckel's cave, and we can follow 5 into the middle fossa and the cavernous sinus. And this is what we did in this particular case. I'm going to skip just in the interest of time, but this is the postoperative view. And you see how we left residual here just around the posterior wall of the cavernous sinus, because that's the area where 6th nerve is entering. And I'm afraid that if I'm too aggressive here, I can get her a 6th nerve palsy, which she did not have. So these are 1 year post-op MRI after radiation. This also was an atypical meningioma, and a patient with a very good outcome. So in the cavernous sinus, we have other lesions too. This was an unusual case. This was a multiple recurrent cranial pharyngioma operated somewhere else all of the time through a transsphenoidal macroscopic approach, where they were doing just minimal resection, just popping the system pretty much. So the tumor kept growing and expanding. And it came to the point where they thought there's nothing else we can do. You see this, an stenotic carotid, very narrow. This patient had radiation 3 times, I believe. So we said, okay, let's go endonasal. He has a complete 3rd nerve palsy, so I don't have to worry about injuring his cranial nerves. So I can do a very aggressive endonasal operation into the cavernous sinus. And in this case, not only into the cavernous sinus, but also in the suprasellar space to remove all this tumor. You can see the optic apparatus is being tethered down because of the previous operations. You can see the clinodal space and clinodal carotid, supraclinodal carotid, the perforating branches. We're trying to dissect all this. You see the calcification on the other side, which we're going to take care of. If you don't remove this portion of the tumor, the patient is going to recur regardless. And we do a very aggressive resection on the sella. That's the distal dural ring. Pay attention to this dura right here. So now we remove all the tumor that is in the cavernous sinus. And I'm going to work medial and lateral to the carotid on both sides of the carotid artery. I'm opening towards the supraorbital fissure. Again, in a patient with intact cranial nerves, this has high risk. But in this patient, he has already a complete 3rd nerve palsy that is chronic, so it doesn't really matter. So I can be really aggressive with it. And then, again, working medial, lateral to the carotid. You can see the optic nerve. We can see the perforating branches from the carotid, the PCOM, very importantly. You see this is the carotid, instruments on each side, just to perform a very aggressive resection. And let me show you at the end of surgery, we got this result, isolated the carotid with no tumor left that we can see in the cavernous sinus. Now pay attention to the tumor around the carotid here in the supraclavicular space, because there is some lining stuck to the carotid that I didn't take, I just coagulated, but the post-op MRI looks clean. So this patient did really well for about 2 years. So 2 years later, he presented with this tumor recurrence right here. And if you look at this tumor recurrence, this is in the roof of the cavernous sinus, in the clinoidal space and supracranial space. It was coming from that dura surrounding the distal ring that I didn't take because the carotid is there. So at this point, we know this is a very aggressive meningioma. Chronopharyngoma, what do we do? So in this case, I decided we need to do an aggressive operation with BTO, which showed that he has severe stenosis of the ICA, radiation induced. So we prepare for a bypass, STA-MCA bypass done at the same time of surgery. After the bypass, we proceed with a carotid sacrifice and cavernous sinus exsanteration and a complete radical tumor resection, as you see here. So the same approach you saw before, Hakuba Doleng technique. You saw the tumor, you see coming from the dura that surrounds the carotid on the cavernous sinus, on the clinoidal space. So what I'm going to do is I'm going to find the carotid, I'm going to find the optic nerve, I'm going to put a clip on the carotid just proximal to the PCOM, and then I can transect the carotid and take the whole cavernous sinus and the tumor with it. And this is the post-op. You see the clip across the supracranial carotid and a complete tumor resection. And this patient is now 6 months out with excellent outcome and no deficits, no new deficit. And I'm really hoping for him this could be the end of it. Although, as you know, chronopharyngioma sometimes are so difficult to deal with. I'm going to move into the posterior fossa and posterior skull base. And as an example, I'm going to show you here, 3 different tumors. So we're going to talk about now or different approaches on the posterior cranial fossa, which we talked about combined transpetrosal, retrosigmoid approach with the variants, transtentorial, suprameatal, or the far lateral with the extreme lateral variant, etc. So when do we use these approaches instead of EA, or when do we combine them? So I'm going to show you some case examples to share with you a bit of my philosophy for these cases. So 3 cases that look quite similar in location and in size, but 3 different approaches for each of them. And I'll try to explain why. So this is a tumor we did through a retrosigmoid, supracerebral transtentorial approach variant. This is a combined transpetrosal approach. This is an endonasal endoscopic approach. So this first tumor right here, this patient presented with this tumor that was sent to me as a petroclonal meningioma. It had been radiated twice, and it had, let me just go back quickly. It had grown in spite of radiations. It had developed in severe ataxia, multiple falls, and you can see the brainstem swelling caused by this tumor. So this didn't look like a meningioma, right? So I put the patient in a lateral position, head elevation, supracerebral approach. This is retrosigmoid craniotomy. We're cutting the tentorium. It's a transtentorial, supracerebral transtentorial approach. I can see the brainstem right here. I can see the tumor right on. I can see that you see the superior cerebral vein. And look at this nerve. That is the 4th nerve that I'm cutting right now. This patient had a 4th nerve schwannoma, a trochlear schwannoma. These are very rare, but they're well known. So I'm all the way anterior until I see the 3rd nerve, the PCA, working through a supracerebral approach, the dorsum sella. I look at the phenomenal route I get from this supracerebral approach, lateral position, and a near complete resection. I said, that capsule that was completely stuck to the brainstem, but a really good outcome. And I thought a perfect choice of approach. I thought in this case, should I go endonasal, given the long axis? But I thought I have better long access to the tumor through a supracerebral transensoral approach, and this worked really well. This other example, so this tumor was a large meningioma. It was done somewhere else, and they left a significant amount of residual. It was done through a retrosigmoid approach. I followed the patient, and in just 6 months, he had increase on tumor size and increasing brainstem edema, which was the most concerning, with worsening ataxia. So what do we do at this point? So we go retrosigmoid again, or should we do something different? So in this case, or do we do endonasal? Not good for endonasal, right? It's too lateral. So in this case, I decided to do a combined transpetrosal. One of the reasons also he has no hearing from the previous operation. So I can do a very extended transpetrosal approach. I worry about how stuck this tumor is to the brainstem and to the trigeminal nerve, and there is no better approach than the transpetrosal, combined transpetrosal, to give me the closest access to the attachment of the tumor and to dissect its interface to the brainstem from the lateral aspect. So here we are doing our combined petrosectomy, posterior and anterior, and now we are cutting the dura and the tentorium, and you see we are right on. My hands are so close to the petroclival junction right now for this meningioma. We're dissecting these veins on the tentorium so I can cut it safely, and I can remove the tentorium with it that has some tumor, and I can really be very close to it. That was the fourth nerve that we're seeing there, and then we see the fifth nerve is really stuck to the tumor. There is no way I would have been able to do this approach or this operation this well through an endonasal approach, through a retrosigmoid. And I can follow trigeminal nerve into Meckel's cave and just working around the tumor, detaching it from its skull base origin. That's the basilar artery, and I can, finally detach it from the brainstem interface, which wasn't very good, but I was able to find a decent plane of dissection to really separate this tumor and have a complete tumor removal. That's now we are taking part of the attachment. We're looking at the clivus, the sixth nerve, and our reconstruction. We use this vascularized, posteriorly based vascularized pericranial flap for this particular case. So a case where this combined transpetrosal really was a perfect option, I think. And you can see the post-op with no residual whatsoever and a beautiful outcome. This one was really difficult case that I thought very much how to do. You look at it, there is a rim of brainstem laterally. So I thought lateral is not good. I want to come anterior. So I either come anterior through a pretemporal approach or I come endonasal. And endonasal is not easy, but I've done a good number of these meningiomas endonasally. And I'm going to have a window between the basilar artery and the carotid artery. And this patient has a sixth nerve already, so I'm not too worried about the sixth nerve in his case. And you see, it gives me such an excellent exposure of the most critical part of the operation, which is the interface between the tumor and the brainstem, in this case, from anterior. You can see here the perforating branches. I had to stop the resection at that level because the perforating branches were completely stuck to the capsule. You see, it's a very good resection, just leaving that little capsule residual stuck to the brainstem without getting any complications afterwards for this patient. So that was a good example of the choice of approaches, which is never easy in these cases. Let's talk, since we talk about meningiomas, more in detail about petroclival meningiomas. This is a very controversial topic. What is the best approach for petroclival meningiomas? The answer is the no best approach. It depends on the tumor. Every tumor is different, and we need to tailor our approach to the tumor and to the patient and to the goals of surgery. So you see, in this case, we have this first case, very large tumor, young patient, multiple symptoms, very large, again, tumor. This one that I definitely am going to do through a transpetrosal approach. This one in the middle, however, is also a large tumor with a middle fossa component. This is an elderly lady. She's 73, which is not that old, but she was very fragile, not in great health, significant ataxia. I just do a simple retrosigmoid. I take all the tumor or most of the tumor in the posterior fossa, and these tumors are very slow growing in general. So I believe this patient is going to do just fine with this approach. And then we have this one, another elderly patient with also ataxia, and this tumor is so ventral that it's almost a clival meningioma purely, that a combined transpetrosal is an option, but still you have so many nerves in your way that I thought endonasal is a perfect approach for this one, and this is what we did in this particular case. So I'm going to show you this example of the combined transpetrosal for such a large tumor, and I think it's so important for us skull vision to have this approach in the armamentarium. I know some students have abandoned it because of the morbidity. I do think that this approach is powerful when it's well selected, when it's well indicated, and when technically you know how to do it well. I think it's important to also work with an expert neurologist. I think really makes these approaches safer and better. So this is the incision we tailored for her. This is the posteriorly based pericranial flap that we're going to use for reconstruction. Very important, so the patients don't get CSF leakage, rhinorrhea. And these are planned craniotomy. As you know, we can do this two ways: craniotomy first, mastectomy later, which is what we did here. I think this is faster. And then the neurotology team takes care of drilling the mastoid, the posterior transpetrosal approach. In this case, we're preserving the labyrinthine. We want to preserve her hearing. She has intact hearing. And now we're doing the anterior petrosectomy. And even in this case, I wanted to have exposure all the way anterior because the tumor was so large that I'm also having access to the meningorbital band. So I do a little bit of the Hakuba technique also. I want to see the cavernous sinus. The tumor is not getting there all the way to the posterior wall, but I want to have as much exposure and as much relaxation of the temporal lobe as possible. Now I'm dissecting the whole petrous apex. We can see the petrous carotid there. I can see V3. And here what is key is to go underneath B3 to really expedite your exposure. I'm going to move a little bit along here. So we are finally opening the tentorium. The first thing I go after is the fifth nerve. And I'm going to follow the fifth nerve. And I open Meckel's cave as it goes into the middle fossa. And that is such an important step, opening Meckel's cave to free up 5. Now taking tumor in the middle fossa. Once we do that, we cut the tentorium. Now I'm all the way in the clivus. And that's the beauty, that I have my dissector right on the petroclaval junction right here. And we see the sixth nerve. This tumor actually had good planes of dissection, relatively soft, which makes this resection so good. And I can do, careful dissection. Again, this is a young patient, very symptomatic. I'm going for a complete resection here, working around trigeminal nerve, and that's 7 and 8 actually right there. And this allows me to finally mobilize the tumor. And at the end of surgery, you can see 5, you can see 7 and 8, you can see lower cranial nerves here, and a very nice complete tumor resection. This is a reconstruction. Remember the importance of the vascularized pericranial flap. And this tumor, this patient had a almost complete tumor resection, except the posterior wall of the cavernous sinus, and with just trigeminal neuropathy, but no sixth nerve palsy or other cranial neuropathies. Just to finish, we have the lower clevial area versus craniocervical junction foramen magnum. When do we use endonasal? When do we use a far lateral approach? And all of this could be a topic for a whole lecture, but I'm going to summarize just with 2 cases. So you see this young kid, 13-year-old, presents with this large mass here, again in the ventral clivus, lower clivus. This patient presents with this tumor here at the craniocervical junction and neck pain. So I look at these tumors and I think, is this tumor above or below the foramen magnum? Is it more clival or is it more spinal? The more clival it is, the better. The more spinal it is, the better for endonasal. The more spinal it is, the better for open, in my opinion. So this first case, this patient I followed for 2 years, and the tumor had progressed and had persistent neck pain. So I did this through a far lateral approach. I learned this from Dr. Caldwell, this oblique incision. I like it very much for tumors that are not too low. And then, perfect exposure. We're going to cut all falciform ligament. We're going to cut our C1 posterior root to get access. Where you see the spinal accessory nerve. I'm going to mobilize the tumor. I'm going to expedite it here. So we get to the end. You see we dissect around the vertebral artery. You have a nice plane of dissection along the brainstem. You want to preserve this posterior spinal artery. So important because it can give you a stroke in the medulla and upper cervical cord. And that's a nice resection with an excellent outcome in this patient. Now, this other one is a real challenge. You see tumor in this area and laterally here along the petrous bone. And in this case, we did, because of the atypical imaging, so dark in T2, we did a biopsy. We did, when endonasal, take a biopsy. It came as a meningeal melanocytoma. Young kid, 13-year-old. What do we do about that? Very difficult case. So I went endonasal, transclival. And for me, lower clival tumors are better than endonasal when they are midline than when they are done through a lateral, transpetrosal, or whatever approach. Basically, because all cranial nerves are around, vessels are around, and you go from endonasal, you have a direct exposure of the tumor. Look at the darkness of the periosteum around the carotid artery. That is a very unique feature of a melanocytoma. So full auscultation of the carotid arteries, drilling of the clivus all the way to the foramen magnum. Look at the dura, how dark it is. That's where the tumor is arising from. This was a really difficult case because the tumor was extremely fibrous, very fibrous, and difficult to resect. But, you know, through tedious work, many hours, you see at the darkness of the tumor, we're able to resect the majority of this tumor. And you see how all the vessels and nerves around us. You can see lower nerves, you can see 7 and 8, then you can see 5 superiorly. I can have direct dissolution of the basilar artery, all the branches, and I leave a little bit of the capsule stuck to the vessels because it's too risky to remove it. But it's a near complete resection. I think this would have been so difficult to run through an open approach, and I think this was an excellent choice. But now we have the component laterally. So then we went retrosigmoid. A few months later, removed the component along the petrous bone, and this kid, you see here his post-op, beautiful endonasal approach with no complications, retrosigmoid for removal of the rest, and you see here the retrosigmoid route and an excellent exposure and approach. And just to conclude, you know, this is the patient here playing soccer here at the Stanford field and trying to jiggle the ball between these 7 different approaches here. So I think modern skull-base surgery is very much about mastering all skull-base approaches. I think for the older generation, it's difficult to master the endonasal approach. I think for us, the younger generation, I think the endonasal approach is key because it adds so much to what we can offer to our patients, but at the same time, we cannot forget traditional skull-base surgery. We need to use and incorporate both for the best outcome of our patients. Thank you very much for your attention, and I'll be happy to take any questions. Thank you.
Thank you very much for such a wonderful lecture, Dr. Fernandez Miranda. I am sure all the audience has learned from your robust experience. Right now, we have a few questions from the public. Do you think embolization might be of help for complex meningiomas prior to these approaches?
In my opinion, or in my practice, the embolization has very limited application. There are some it can be very useful, but the problem is that the tumors that are very large that you want to embolize, they're very large. Those are risky because you can cause further swelling when you embolize, and I always worry about that. I've seen patients deteriorating overnight after embolization. So yes, there is a role, but I'd be very careful about it. And also, there are many tumors that you want to get the feeders that, for example, come from the cavernous sinus carotid, and those are not easy to embolize and is risky. So the feeders that are difficult to get access in surgery are also difficult to occlude with embolization. So you really need to have a good expert in embolization to take care of those, and there are risks with that.
Thank you, sir. Here's another question. Do you think TONES approaches is an alternative for any of these pathology in the paraclinoid paracellular region?
Yeah, I mean, the TONES is a global concept, no? But I've done many times this, what we call the lateral orbitotomy approach, or eyelid crease incision to do Middlefoss pathology, to do especially like intraosseous women meningiomas, for example. I've done also some small craniotomy meningioma can be done that way too. I do think that there's a role for them, of course. I think it's usually my preferred approach, the lateral orbitotomy, for intraosseous women meningiomas that are relatively small, not too extensive, in which case I need further reach. So yes, of course there is a role, I think, and the role is increasing, in my opinion.
Thank you. Which are the most feared complications from these approaches? Which options for controlling them do you have?
Say that again?
I'm sorry. Which are the most feared complications from these approaches, and which options for controlling them do you have?
I mean, that's a very general question. If we talk about endonasal, for example, of course, the risk of spinal fluid leakage is always in our mind, especially when we do intradural pathology, obviously. That's why I have, to some extent, avoided doing large anterior skull-base meningiomas through an endonasal approach because the exposure is very large and the risk of CSF leakage is significant. And a craniotomy has little morbidity and manipulation of the brain. So I think the risk of leakage, for example, in that area is not worth it for very large meningiomas. Now, I'm not talking about tuberculum cell, I'm talking about large or giant olfactory meningiomas. Now, if we talk about transclival approaches, yes, there is a risk of CSF leakage, but that risk is worthy, in my opinion, in many cases, because the alternative is an approach that has higher risk of not CSF leakage, but maybe coronary palsy or brainstem injury, etc., etc. So it's all about a balance and trying to find what you think has the best risk profile for that particular patient, that particular tumor.
Thank you, sir. What is the role of endoscopic endonasal approaches for the treatment of vascular pathology, particularly aneurysm?
I do think that the role is very limited. I think it's not zero, but it is maybe 1% or less than aneurysm will be treated with an endonasal approach, even in very expert hands. I do think that, if there were not pipelines or colon embolization, we would be seeing more endonasal approach for aneurysms, but all the posterior circulation, basilar aneurysms, etc., are very well done with endovascular techniques. ICA aneurysm, for example, are very rare, but an ICA coming directly from the basilar artery origin seems to be ideal for endonasal, just because it's such a long reach from a retrosigmoid or far lateral approach. I do not think ACOM aneurysms should be done endonasally because they're above the optic apparatus. And I think that really requires manipulation of the optic nerve. That's completely unnecessary when you can do it from above very well. Paraclinical aneurysm is an interesting area. Those that are projecting medially underneath the optic apparatus in the infracosmetic space, those are, I think, very appealing for endonasal approaches, although it's very controversial, but very appealing because you have excellent proximal control in the cavernous sinus directly. You have the limitation of not good distal control though, but you have minimal manipulation of the optic apparatus, and you can put a clip that is just parallel to the supracosmetic carotid and clip the aneurysm that way. So it's an area where I think is very promising, paraclinical aneurysms, certain ones.
Thank you, sir. There's another question. Is it really accurate, the use of intraoperative doppler when trying to identify the carotid artery just before the dura opening, or do you rely more on neuronavigation?
I do rely more on the doppler, always. I have the doppler with me in every case. I use a doppler that is reusable, so I don't have to spend on those non-reusable dopplers. It's an extremely useful thing. I use it compulsively during surgery, especially when I'm dissecting around the carotid and the planes are not clear and the tumor is stuck and you don't know exactly where the carotid goes. I use it all the time. Of course, navigation too, but navigation is not as reliable as Doppler. So I advise everybody to use it.
Thank you. Is there any role of robotic surgery in order to improve safety in endonasal approaches?
I wish, no, but I don't think we have that developed yet, as far as I can tell. I do not see an immediate future personally on robotic surgery for endonasal skull-based surgery. Other than perhaps, and I don't know if my ENT colleagues or anybody is listening, but other than perhaps maybe using a robot to drive the scope with you, or some very precise procedures like, draining of a cyst, putting a needle somewhere. I think, what we do in the nasal is so complex technically. It requires multiple, manipulation of structures and techniques that I don't think a robot is able to handle that at this point.
Okay, sir, there's another question. What's your opinion about using endoscope-assisted surgery through an open approach for a pontocerebellar angle lesion?
Yeah, I think it's a routine thing for me. Whenever I'm doing a posterior fossa approach and I feel that the microscope is not giving me the visualization I need, I would add the endoscope. It's seamless at this point. You can add the endoscope very easily. I would say that it's especially useful or particularly useful in, for example, epidermoid tumors. Because remember, the endoscope gives you visualization, but at the same time, you need to have access and ability to get all the way there with your instruments. And sometimes what you can see, you cannot reach. An epidermoid tumor is something that doesn't require very fine dissection technique, because it can usually be aspirated or scooped out. Those are the ones that I think are most useful. But yes, the endoscope is always a useful tool to have handy.
Sir, there's another question. In your experience, can these approaches be performed using the 3D exoscope visual aid?
You mean the open approaches?
I guess he's trying to ask.
Yeah, because there's
open approaches, the exoscope, yes.
Yes, of course, and there are students doing it. I've tried it. I think the exoscope provides beautiful visualization. It really is spectacular, the quality of the imaging you get. I really don't see, personally, I have no conflict of interest, but I like myself the integration with the microscope. I like to operate with a mouthpiece. I like to have my hands in the field and being able to move the scope carefully with my mouth, and you're used to that dynamic of working with the microscope and the technique. That being said, I think the exoscope is something very interesting and allows you to maybe have a more collaborative surgery, having a co-surgeon seeing and everybody in the room seeing the operation. So definitely I would encourage people to explore it and see what they think.
Thank you, sir. What do you do when you get a vascular carotid accident?
So the first thing I do is not get a vascular carotid injury. That's the first thing and the most important. Do everything in your hand to prevent it. And I can tell you that nobody's free of injury of the carotid, of course, but if you are meticulous, if you are careful, if you follow the anatomy, the principles of the anatomy, the technical principles, you can really do very well. I have been able to avoid a carotid injury for more than a decade and, over 1,500 cases. And I haven't had one. And I'm going to have one anytime because that's the nature of what we do. And I do all the time tumors around the carotid and all the time at the edge of getting an injury. So that being said, first be very careful. Now, if it happens, you need to have a plan ready. You need to have your team ready on what to do and how to do it. And I'm not going to reveal the steps because it takes some time, but ultimately, if you need to identify the type of injury you have, if it's just a pinpoint injury on the carotid, you can maybe just silk with coagulation. If it's maybe a perforating branch coming from the carotid, that's very easy. Although it could be nerve-wracking because you never like to see bleeding from the carotid, but I have that many times, a number of times from the carotid in the cavernous sinus. But it's not the carotid itself. It's the inferior hypophyseal origin is bleeding. You can coagulate. That's easy. Now you have a real hole in the carotid, a real tear in the carotid. You need to assess whether it's repairable or not, and then you can use a large muscle patch and put it and keep pressure for minutes until it stops. And if that's not enough, you're going to have to pack the whole thing and go to the endovascular suite. Sometimes it could be an injury that could be repairable with or reconstructed with clips. I always have a set of clips with a special clip applier, and you can reconstruct the carotid with clips. You can wrap it. You can try to clip a sidewall clipping. So there are a number of things you can do.
Sir, do you use always a nasoseptal flap for reconstruction?
No, of course not. It depends on the tumor, right? On the case. I use it always when there is a high flow CSF leak. But if it's a low flow CSF leak, I will use it judiciously. Usually for pituitary adenomas, rarely, sometimes, but not very often. For, intradural tumors, suprasellar tumors, transclavial approaches, always. And not only that, but especially in transclavial approaches, I use a multi-layer reconstruction with fat cellata, with fat graft, and then with the fat graft and the flap and a lumbar drain.
Thank you, sir. We have another question. What is your opinion about to treat brainstem lesions by endoscopic and nasal approaches?
Well, I've done myself a few, but very selected. It has to be a purely ventral lesion with no lateral extension. If it becomes lateral, then Lateral and high, a petrosectomy is a good approach, or a subtemporal if it's high enough. If it's low, you can do far lateral, transpetrosal. There are many options, but if it's purely ventral, it is a good option for endonasal, or it could be if you're experienced. I would not recommend doing it if you're not experienced with it. The same way I would not recommend doing a skull-based approach complex if you're not experienced, right? But yeah, I think there is a role for purely ventrally located skull-based lesions, or cavernomas, or some chordomas, or even the glioma some years ago. So there are lesions you can do through an endonasal approach in the brainstem.
Thank you, Dr. Fernandez. I think that's all the questions. On behalf of CN, I'd like to thank you again. This has been a wonderful lecture. We are already grateful and honored for your participation in the 2021 IWBNC. For all the audience, keep in mind this lecture will be available on our website starting next week. In a few minutes, we will have Dr. Koi Tan doing his lecture, Minimally Invasive Anterior Colon Release in the Treatment of Spinal Deformity. To get the link for this upcoming conference, please follow the link pinned on the chat screen, or check the program schedule on our website, cnus.com. Thank you very much, Dr. Miranda.
Thank you.
We really enjoyed your lecture.
Thank you. Bye-bye.
Bye-bye, sir.